Hello and welcome to the webinar. My name is Sabrina Edgington and I'll be serving as both moderator and presenter for today's webinar, an overview of proposed minimum standards for medical respite programs. This is a production of the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration, Office of National Assistance and Special Populations, and this session is being recorded. This is a 1.5-hour presentation with time reserved for Q&A. Below the presentation slide, there's a chat box for participant questions and technical issues. So please type your questions or technical issues into the chat box at any time during the presentation. A selected number of questions will be answered at the end of the presentation during the Q&A session. Please note that any questions or comments entered into the chat box will not be considered a formal public comment for purposes of amending the proposed standards. A link to an electronic form for submitting formal public comment will be provided at the end of the presentation and is also available on the medical respite page of the National Healthcare for the Homeless Council's website. A copy of the proposed standards is available for download in a files pod on your screen. It's also available on the same medical respite page with the electronic public comment form. And the PowerPoint presentation and the recording of this webinar will be posted on our website, www.nhchc.org, within 72 hours. At this point, I'd like to briefly tell you a little bit about myself and Dr. Jessie Gaeta, who will be also presenting on today's webinar. As I mentioned earlier, my name is Sabrina Edgington. I manage the day-to-day activities of the Respite Care Providers Network, and I'm currently leading a 3-year national demonstration program supported by the Center for Medicare and Medicaid Innovation to demonstrate the impact of medical respite care on health, quality of care, and system costs. I'm also your liaison at the National Healthcare for the Homeless Council for anything having to do with medical respite care and supportive housing. So I encourage you to contact me if the council can be of any assistance to you in your work in these areas. And my contact information will be available on the Q&A slide. Dr. Jessie Gaeta is the medical director of the Boston Healthcare for the Homeless program. Prior to serving in this role, she was the medical director at Boston's Medical Respite Center, the Barbara McGinnis House. The Barbara McGinnis House is one of the first medical respite programs to be established in the United States and is a leader in medical respite research and practice. Dr. Gaeta is also the chair-elect for the Respite Care Providers Network Steering Committee and is a member of the task force that worked on the proposed standards. Jessie and I will be toggling back and forth to be talking about these standards during the presentation. So during this webinar, we hope to do a few things. We hope to talk about the rationale for developing standards, the process for their development, and then we'll move into an overview of the 7 standards, which will be followed by a description of next steps and Q&A. So for those of you who are unfamiliar with medical respite care, it's defined as acute and post-acute medical care for homeless persons who are too ill or frail to recover from a physical illness or injury on the streets, but who are not ill enough to be in a hospital. These programs provide 24-hour access to a bed, coupled with clinical and supportive services. They're delivered out of a variety of settings, including homeless shelters, motel units, apartments, nursing homes, assisted living facilities, and standalone facilities. Currently, there are over 70 medical respite programs that we know about operating in the United States, and a good number are in the planning process. We believe that medical respite care is a critical component to the continuum of care for people who lack housing. And a major goal for the Council is to secure sustainable federal funding for these medical respite programs. However, one of the challenges that we face is that there aren't any clear guidelines for what constitutes medical respite care. As such, when we meet with federal administrators to discuss financing, questions arise about scope of services, intensity of care, accountability, and program impact. We hope that these proposed standards lead us to a point where we can say with certainty that all medical respite programs meet a standard of care and are inclusive of high-impact evidence-based practices. We hope that these standards will help us get to a point where we can improve consistency across a range of programs. Right now, programs are incredibly unique, and the only common factor really is that they're all providing 24-hour access to a bed. We hope to align medical respite programs with system-wide efforts to meet the triple aim of improving quality of care and health outcomes while reducing healthcare costs. And by providing a baseline for care, we hope to improve opportunities for research, particularly research that looks at the scope of services that lead to positive outcomes at the individual level and at the systems level. As I mentioned earlier, we hope that all of this will position medical respite programs to receive sustainable federal funding in the future. And we hope that in the end, we'll have systems in place to avoid the patchwork respite phenomenon that is occurring in communities when no funding is available for this service. Despite the best intentions, a recent study coming out of Duke University found that these patchwork respite programs often come at a very high human and monetary cost. And at this point, I'll let Jessie talk a little bit more about the process that we use to develop these standards.
Good afternoon, everyone. Thank you for joining us. Before I explain the 4 goals that we had in mind in developing the standards, I thought I would back up for a minute and just say and sort of acknowledge that as you saw from Sabrina's map of the United States, we are a very diverse geographically and in every other way group of programs that are currently providing medical respite care. So I thought it would be good to just acknowledge at the outset that despite having a very wide range of programs, that at this point in time, we need to collectively take a step forward to really define medical respite on a national level. And this is in order to be recognized and to gain legitimacy among government agencies, payers, and regulators. This step forward, however, I think necessarily has to involve some compromise, and I think you'll see that reflected to some extent in the proposed standards today. So these standards are really not intended to be a one-size-fits-all approach to medical respite, but rather a framework to help programs operate safely and effectively. So the four goals that we were aiming for in these proposed standards are to first and foremost really reflect the needs of the patients who are being served in a medical respite setting. Of course, we also want to make sure that we're promoting improved health and very high quality care. Ideally, we can align as much as possible with other sort of similar industry standards, such as the NCQA's Patient-Centered Medical Home Standards, JACO standards, or long-term care standards. And we've reviewed all of those in thinking about what medical respite standards should look like. And finally, and this is also very important, our goal was to make achievable these standards for a range of programs that have varying resources. The process to date has been a long one, and it has really happened under the leadership of the Respite Care Provider Network, the RCPN. And within the RCPN, we've had a standards development task force that has been working on these standards actually for the past more than 2 years. The standards task force, and I'll list the representatives in a minute, I would just like to point out represents various disciplines and viewpoints, including consumer viewpoint. So we had monthly meetings as a task force since the fall of 2011, so I guess I should say 3 years. And after a lot of debate, we sort of ended up deciding that the proposed standards would be to focus on the minimum standards, so a minimum threshold of meeting standards that programs would have to meet to gain accreditation under these standards. This is just a list of the task force members and what program they're associated with across the country. You'll notice that we have programs represented here from Seattle, Philadelphia, Boston, Chicago, Houston, Asheville, North Carolina, San Francisco, Minneapolis. So the standards, this is the broad outline of the standards. They are a relatively simple list of 7 standards. And the quick summary of each one is as follows. Standard 1 relates to accommodations. Standard 2, environmental services. Standard 3, care transitions into medical respite. Standard 4, clinical care. Standard 5, care coordination and support services. Standard 6, care transitions out of respite. And Standard 7, quality improvement. I'm now going to turn it back to Sabrina to jump right into Standard 1.
Thank you, Jessie. So Standard 1 is probably the most basic of all of the standards. It focuses in on accommodations, and really we just want to make sure that medical respite programs are providing safe and quality accommodations. That means that patients have 24-hour access to a bed and that the accommodations are hygienic. So patients have access to shower facilities, laundering facilities, clean linens, and janitorial services. One of the elements of the standards is to ensure that your environment or the settings of medical respite care is accessible and minimizes fall risk. We also ask that medical respite programs, or we propose that medical respite programs, offer secure storage. So if there are not already a system in place to store medication, as many programs do not have the authority to store or dispense, we ask that at minimum that you provide secured storage for patients to be able to put away their personal belongings as well as their medication if it's appropriate. The accommodation standards also covered food, so we would hope that medical respite programs provide 3 meals daily. It notes that medical respite programs should have 24-hour staff presence. This doesn't necessarily mean that you have 24-hour clinicians on site. It means that you have somebody on site who is trained in first aid and basic life support, and that they know how to call 911 or know when to call 911 or when to call on-call medical support if needed. There are some certain exceptions for non-congregate facilities, for example, for those types of programs that are based out of motel rooms, and that is to make sure that your patient, as well as the landlord or other administrators of the building, understand how to contact the on-call medical support. We also propose safety plans, and that means that there are policies and procedures for responding to life-threatening emergencies. For example, medical emergencies. What would you do if a patient all of a sudden starts to have some kind of emergent situation or maybe isn't breathing? What is that policy and procedure that your staff follows? There should be patient understanding of fire and evacuation plans and a code of conduct so that people know coming in what's expected of them in terms of their behavior and interaction with staff. And we also propose that there's a policy for handling alcohol and illegal or non-medical prescription drugs. So, for example, if these are confiscated in your setting, how is it that your staff is going to handle those drugs? And then also, in the same respect, a policy for weapons and staff response to violence. So in the event that you do find a weapon, whether it be a knife or a handgun, how is it that your staff manages how is it that they determine what they do with that handgun? What are the protocols for reporting that? And then how does staff respond to violence? Do you have a de-escalation program at your site? We all know that we work with a lot of people who have experienced trauma, and it's always good to have some kind of training for staff in order to be able to respond to violence in a way that's not going to escalate the situation any further. And at this point, I'll give it back over to Jessie to talk about our second standard.
Thanks, Sabrina. Standard 2 focuses on environmental services. The goal of this standard really is that medical respite programs are providing quality environmental services. And those can roughly be described in 4 basic categories. And I'll talk about some of these in a little bit more detail in the following slides, but they include the safe handling of biomedical and pharmaceutical waste, such as storage, handling, and disposal. This particular standard also refers to how to manage expired and unused medications or needles. Infection control falls under Standard 2, environmental services, and this standard really has to do with how we manage bodily fluid exposures and infectious diseases that can be transmissible. I'll talk a little bit more detail about that as well in a minute. Medication storage really has to do with following manufacturers' recommendations and also assuring that there's some periodic inspection to verify that medications are stored properly. And the last standard here under environmental services is simply pest control. And for this, we're really hoping that programs will have a contract in place for some routine and maintenance pest control. I'm going to talk about a couple examples having to do with Standard 2 environmental services on the next slide. But let me just state too that for Standard 2 that we're really looking for programs to have written policies and procedures in each of these categories. Just a quick cartoon. Good news. It's not the bird flu or the swine flu. It's just an ordinary flu. But even the ordinary flu probably needs some infection control measures. And there are lots of other communicable diseases that patients suffer from that we need to be able to manage well in a medical respite setting. And I found that the CDC provides terrific guidance for hospitals, and they sometimes provide guidance for shelter-based settings or congregate-based settings. They certainly don't specifically provide guidance around individual infections for medical respite programs, so we're always kind of reading between the lines and trying to figure out how we fit in. As an example, here we go. I'll just share with you a couple different approaches to influenza across the country. So in San Francisco, the medical respite program there requires 5 days of treatment with an antiviral called Tamiflu, or that the patient is 48 hours without a fever, afebrile, before they're admitted to respite. In Seattle, the program there requires 24 hours without a fever and on antiretrovirals. In Boston, we are able to take patients into medical respite and institute droplet precautions, and we also initiate Tamiflu in-house. So you can see that this standard isn't really meant to be very prescribed for individual programs, but that individual programs have thought about the resources available to them and how they may best prevent transmission of infectious diseases. And most programs will be basically figuring out which conditions require simple standard universal precautions versus contact precautions, or even droplet precautions, and in some cases even airborne precautions. I wanted to just make a couple statements as well about medication storage. So programs basically are probably going to be licensed through their departments of public health in different ways. And one variable that's very important to understand is how programs are licensed to either administer or dispense medications. And programs can be set up to do either. So for medication administration, this is really a scenario where a registered nurse is responsible for medications. The nurse holds on to medications. They're under lock and key, and they are administered to a patient by a nurse under the 5 rights: the right patient, the right drug, right dose, right route at the right time. Versus medication dispensing, where the nurse is really acting as an assistant to the patient who's sort of self-administering the medications. So there are different ways that medications can be handled in medical respite. And these standards recognize that there are different ways. Again, I think I mentioned before that medication storage needs to happen according to manufacturer requirements. I was thinking of just a couple special considerations that we come across all the time in medical respite settings. For instance, the fact that some medications like insulins should be refrigerated at certain temperatures. Of course, with controlled substances, there's a lot more expectation and regulation around how these are counted and accounted for and stored safely as to prevent diversion or misuse. And the regulations for controlled substances vary by state. In California and Massachusetts, for example, there is regulation here that require that controlled substances are under a double lock. So, for example, in a medical respite facility, they might be located in a nurse's office, plus there may be a separate narcotic or controlled substance cabinet with a lockbox. Just thought I would mention outpatient chemotherapy regimens as well. As you know, the treatment of cancers is increasingly moving into the outpatient sphere, and as such, I think respite programs across the country are increasingly asked to have patients who are undergoing outpatient chemotherapy regimens. Some of those are oral that the patients have with them, and some of them are administered in an outpatient clinic intravenously. But these agents often require special storage and handling. And so as medical respite programs, we have to make sure that these are medications that our programs can handle before we accept a patient. Some of them require special gloves, double gloves, special temperatures, etc. And while our program might be able to handle some special needs around certain medications, it's also imperative, obviously, to assess whether a patient or a client has the ability to follow with certain precautions as well. At this point, I'm going to hand it back to Sabrina for Standard 3.
Thank you, Jessie. So Standard 3 covers transitional care. So this is care transitions into the medical respite setting. And it's titled, the medical respite program manages timely and safe care transitions to medical respite from acute care, specialty care, and or community settings. And for those of you who are unfamiliar with care transitions, I did offer a definition. And the definition is the movement of patients between healthcare locations, providers, or different levels of care within the same location as their conditions and care needs change. And this may include transition from the hospital to a primary care provider or home or nursing facility. Right now, transitional care is a huge buzzword in health reform discussions because of its impact on readmissions, reduction of medical errors, and just improved quality of care. And there are a number of evidence-based models, as well as ongoing federal initiatives to test approaches for various populations and various circumstances. So if you think about our patients and the different providers that they see, it can become very confusing, particularly when each provider may not be speaking with each other and the patient may be getting different instructions from each of the providers. So transitional care is a component of care coordination, and it helps that patient from getting lost in the system, and it helps all parties involved, including the patient, to stay on the same page regarding plans of care. And it includes certain general elements. For example, one element is that transitional care programs include patient education and training to improve patient self-care skills. It also means that patient-centered care plans are shared across settings, standardized information exchange between transferring and receiving provider. For example, in this case, it might be that there's a standardized information exchange between the hospital who is transferring the patient to the medical respite program who is acting as the receiving provider. It also includes components of medication reconciliation, assistance to getting to healthcare appointments, and formal handoff procedures so that the patient and the providers know who's accountable for that patient's care at any time during that transition process. So what we did is we tried to integrate different elements of care transition into the standards. And we thought it was an important enough element to have its own place in both Standard 3 and then later in Standard 6 as patients transition out of medical respite programs, because medical respite programs are very well positioned to provide this level of care for patients experiencing homelessness. And for purposes of this webinar, what I've done is I've categorized some of the elements within the standard under pre-admission and admission. So under pre-admission, what we propose is that medical respite programs work with hospitals to promote medical respite as a discharge option. So at minimum, the hospital knows to offer it when it's appropriate. We ask that medical respite programs offer trainings to promote appropriate referrals from the hospitals. Sometimes hospitals want to send patients who may still be a little bit too sick to be at the medical respite setting, and we don't want to have patients going back and forth between the settings. We want to make sure from the onset, before any arrangements are made for transportation, that they are an appropriate referral. We also ask that timely admission decisions be made by a qualified medical personnel, so that if a referral is made, admission decisions aren't postponed for several days, that they're made in a timely manner, and that the right person is making that admission decision. We also ask that admission decisions be based on the ability to keep patients safe and provide the care, treatment, and services needed by the patient. So the medical respite program should be responsible and accountable for being able to accept patients that they can provide adequate care for. And that we also ask that there's communication with the referring agency, whether it be a hospital or another primary care provider, when beds are not available or when a referral is denied. In terms of admission, we ask that there's a designated point of contact for referring entities, so that when an institution is attempting to refer a patient, they know exactly who to talk to and who to ask questions of in terms of their patient health, the patient status, or any referrals coming in. We ask that transportation responsibilities from referring entities to medical respite is outlined in any written agreements. What we know from a lot of literature is that a lot of patients are lost in between that transition between one setting to another. So you want to make sure that transportation is available that will help that patient get to point A to point B. We also propose that protocols are in place for transferring patient information, and obviously that needs to be in accordance to HIPAA law. We would like to see medication reconciliation. So at minimum, you're verifying with the referring provider that medication reconciliation occurred at that setting. And if not, then you'll do it at the medical respite program. At the medical respite program, we propose that the medical respite program reinforce discharge instructions. So we know that discharge instructions are provided, say, for example, at the hospital, but we want to make sure that that patient education is happening on site, particularly since this is a really good time to be focusing in on wellness. We want patients to be able to understand how to manage their health before they leave the medical respite setting. And we also want to make sure that the patient has and knows his or her accountable providers at all points of the care transition. So the patient understands who their primary care provider is and knows when that provider is accountable for their care. Is that provider accountable for their care during the stay at the medical respite program or accountable for their care after their stay? And they know that it's their primary care provider that they go to and not necessarily back at the hospital where they may have, where they were seen for the acute condition in the first place. So at this point, I'll hand it over to Jessie to talk a little bit about the clinical component.
Thank you. Standard 4 was the one that we probably spent the longest time on as a task force and as a committee. And it's the one that I think was probably the hardest to come up with some minimum standard and agreement and compromise on. So Standard 4 is the standard that really sets the expectation that care that is administered is high-quality post-acute clinical care. And first and foremost, the expectation of this proposed standard is that clinical care is provided during and in the context of a medical respite stay. Clinical care in this proposed standard ensures that an adequate level of care, which really sort of translates into an adequate level of staffing, is provided to meet the patient's needs. And so you can see in this standard where there's really room to interpret what your patient's needs are and what kind of patients who will be using the program, what kind of patients those are, and that we're trying to sort of get to this notion of the level of care that you provide, the level of staffing you provide really needs to match what the patient's needs are. And furthermore, this standard proposes that it's required that qualified medical personnel and a medical record is in place. Programs really need qualified medical personnel to assess baseline patient health, to make ongoing reassessments to determine whether clinical interventions are effective, and also to determine readiness for discharge from medical respite programs. Clinical care, however, may be provided on site. It also may be provided off-site by a partner organization, as long as all of the criteria are met. Furthermore, and this should sound very familiar to everyone, the proposed standards really set the expectation that care is patient-centered and that it also reflects interdisciplinary collaboration. To get into a little bit more detail about the standard for proposed elements, the first is that there is a baseline clinical assessment, and that baseline clinical assessment really needs to determine what the diagnoses, the history, a patient or client's allergies and medications are, their physical and behavioral health status, functional status, what their psychosocial needs are, what their level of pain is and how that will be managed, etc. So a baseline clinical assessment is necessary. The second element here is that there should be generated an individualized care plan, and that care plan really should clearly delineate what the treatments are, what the desired outcomes are and goals, and also what indications for discharge would be. The frequency of clinical encounters in a medical respite program really should be based on need. So this is not an overly prescriptive element, but really allows programs to determine which patients can come, are able to be admitted, and to base the program and who their staff are and what the frequency of clinical encounters is, really based on what the patient's needs are. Let me give you some examples of the way that clinical encounters, the frequency of clinical encounters happen in some parts of the country. So some programs have nurses who are on site, varying number of days per week. Some programs have nurse practitioners, physician assistants, or physicians who are available as consultants to nurses when needed. Some programs have providers, nurse practitioners, PAs, or physicians on site for consultations or even to accomplish admissions, deal with urgent issues, pain medication management, and pain and medication changes. Some programs have care that is delivered, clinical care that's delivered by a partner agency that isn't necessarily in-house at the medical respite program, but maybe on a different floor or in some close proximity, but at a slightly different address. Furthermore, the expectation in these proposed standards is that there is an interdisciplinary care team, and this language should sound very familiar from patient-centered medical home. This care team would regularly review cases in a case conference to discuss patients' progress and to reevaluate the goals of care. Furthermore, the expectation here is that clinical practice guidelines that are evidence-based are generated when necessary, and some examples of those might be how the program responds to emergencies, when patients need to be sent to a hospital to a higher level of care, what are some basic reasons why that should happen. Some programs may have practice guidelines in place for fall prevention, or clinical guidelines such as the management of withdrawal syndromes. And there are many others as well as examples. Finally, after a lot of debate, we landed on an element here that we call the Q24-hour wellness checks. And this is really setting an expectation as a minimum standard that wellness checks are conducted by medical respite staff, not necessarily clinical staff, at least every 24 hours during the course of a medical respite stay. I'm going to also describe Standard 5, and this standard is care coordination and support services. The goal of this standard is that medical respite programs are able to assist in healthcare coordination, also a very familiar term as part of payment reform and healthcare reform, and also that medical respite programs provide wraparound support services. And there are two slides on this standard. The first one has to do with care coordination. So as you know, medical respite programs are really uniquely positioned to coordinate care for complex patients who otherwise face barriers to adequately navigating the healthcare system and engaging in support systems. So care coordination really can improve the navigation of the system and the brokering of linkages to community and social supports to help patients transition out of homelessness even. Care coordination, we really have we define a little bit here as, first of all, including self-management goal setting, and this should also be very familiar from patient-centered medical home standards, that patients are able to identify for themselves, really, and with the help of a care team, sort of short-term goals that are most important to them. Care coordination also includes medication reconciliation, assuring connection to primary care, providing access to transportation, if not transportation itself, to medical appointments and to support services. Very important element of care coordination is facilitating specialty care follow-up, and that communication with any outside clinicians comes full circle, and that the medical respite team communicates with the outside clinicians about the care plan and the clinician's input on the care plan. The second sort of domain of Standard 5 here is just the support services that are typically delivered via case management. And the types of support services that medical respite programs are positioned to provide as part of these proposed standards are facilitating, when possible, access to housing, of course, assistance with benefits, referrals to substance use treatment programs, social support groups, and even connection to family when that is desired. At this point, I'm going to pause for a minute to go through a quick case example that I think helps to illustrate some of various of these proposed standards. This is a real case of a 54-year-old woman who had been recently diagnosed with non-Hodgkin's lymphoma, who was referred to our medical respite program in Boston from a hospital locally to make it possible and safe for her to receive outpatient chemotherapy. And for the clinicians on the webinar who are interested, quick side note, the presentation of this case was very interesting and profound. This patient really presented first to a shelter in Boston with a 50-pound weight loss and urinary frequency. She was found in the emergency room to have a very severely elevated calcium level of 18, and the workup that was facilitated in the hospital revealed lytic lesions of her spine and as well as a splenic mass. Bone marrow biopsy confirmed a non-Hodgkin's lymphoma at stage 4, which is the highest stage. And chemotherapy was started in the hospital intravenously via a permanent portacath. Additional pertinent history includes the fact that this patient has been chronically homeless. She's very disconnected from any family, and she's exhibiting some paranoid behaviors, and yet has had really no prior mental health care. So this referral was reviewed by a medical respite nurse, and because of the complexity having to do with the chemotherapy regimen, the nurse had access to a medical respite physician about the specific chemo regimen and what the expected side effects would be in assessing whether this referral was appropriate for medical respite. The patient was accepted, and the clinical assessment was conducted by a nurse practitioner on admission to medical respite. The nurse practitioner who did the initial assessment and became part of the patient's care team generated an individualized care plan that consisted of these elements and actually many others. And the first and foremost was that this care plan really aimed to gain a better understanding over time of this patient's particular goals of care, especially since she was coping with a very significant new diagnosis. The chemotherapy was to be administered in a nearby outpatient oncology clinic once every 3 weeks for a total of 5 cycles. The oncology clinic, in this case, followed the labs and communicated all information back to the medical respite team. Possible side effects were anticipated, and those included alopecia or hair loss, nausea, fatigue, and leukopenia, or a low white blood cell count. And this is critical to sort of care coordination and care planning. Specific plans were made to manage each and every side effect in consultation with the oncologist. There's clear guidance given to all members of the team about when this patient would require transfer back to an emergency room urgently. It was arranged for the patient to have a psychiatry consult, and the team planned to begin exploring the possibility of reconnecting the patient with family and as well as exploring housing opportunities. I'll just summarize briefly and simply the respite course. Interestingly, the patient's paranoia proved to be metabolic. It improved dramatically as the high calcium levels normalized as this cancer and tumor burden improved. The patient was actually reconnected with her sister. She was able to complete 5 cycles of chemo, actually 6, 1 in the hospital and 5 during stays at the medical respite facility. She was briefly rehospitalized after cycle 4 for a severely low white blood cell count and fever. The patient engaged in cancer support group that was located at the hospital. She experienced a very dramatic response to chemotherapy with a decrease in the tumor burden. The team was able to submit a disability application that was pending during most of this stay, and ultimately she was discharged to live with her sister and have much longer-term follow-up, which is very good news for this patient after a very important respite stay that made this therapy available to her. At this point, I'm going to turn it over to Sabrina to dive into Standard 6. We're almost done.
Great. Thank you, Jessie. So Standard 6 is focusing in on the care transition out of medical respite. And the standard states that medical respite programs facilitate safe and appropriate care transitions from medical respite to the community. And so what this means is that we're proposing that discharge planning begins early in the process, and that's something that most of you are already probably familiar with, and that you have discharge policies and procedures, including who makes that discharge decision. We also propose that patients receive at least 24 hours notice prior to discharge from medical respite, and there are some exceptions for administrative discharge. For example, when a patient is asked to leave because of violent behavior. This means also that we're proposing a discharge summary to the patient and community provider assuming patient care. So that way the patient has that discharge summary, and then the provider who's assuming care knows what was going on at the medical respite facility, any follow-up instructions, any lab tests pending, and so that they can continue that level of care in their next setting. And we also propose that patients are provided with options for placement after discharge. This is a standard care transition element that patients or patient-centered care element, and that patients have a choice as to where they go. And so that might mean if if you don't have housing available, and in a lot of communities housing isn't available, you're talking about some of the other different options. For example, whether or not the shelter might be an appropriate place, or transitional living facility. So there are a number of different options, or with family, as in the case as within the case scenario that Jesse had just mentioned. And so our final standard is Standard 7 on quality improvement, and I'll let Jesse walk you through that.
The goal of this standard is that care is driven by quality improvement, which, as you know, is really a systematic and continuous set of actions that lead to measurable improvement in healthcare services and health status of targeted patient populations. And so the expectations under this proposed standard is that there is a process that is in place for collecting and keeping secure data. Furthermore, there is a written quality improvement plan to respond to trends in outcome measures, including patient satisfaction. The quality plan should set priorities for data collection. Part of quality improvement as well is making sure that untoward events or incidents are reported and reviewed on a regular basis. And furthermore, that the program performs self-audits of the quality of care and the documentation of that care. Under quality improvement, we also propose a few expectations having to do with staffing and qualifications of staff. And one is that there be a medical director in place who is a physician. Obviously, that's a position that could be contracted for, doesn't necessarily require a full-time position. Furthermore, that the number, and we were sort of getting to this in Standard 4 as well, that the number and qualifications of clinical staff matches the patient's needs and complexities. Job descriptions and competencies are clear. Clinical staff are actually formally credentialed, and that's basically a process by which a program verifies that that clinical staff, that their licensure, board certification, et cetera, are intact. A medical respite program would be expected to perform annual performance reviews, and furthermore, there is an expectation in this proposed standard about staff education and training. And some of the examples that we think are important in terms of staff education and training include training about the HIPAA law, de-escalation, cultural competency, perhaps even blood-borne pathogens training as a way to prevent transmission of infections, as well as training about the process for incident reporting. In the last slide of Standard 7 here, I just thought I'd give some examples, although I could think of hundreds more, but just examples of things metrics by which we might measure the quality of care delivered in a medical respite program. Some programs are measuring process outcomes, like whether or not a patient is connected to a primary care provider, either in the course of the medical respite stay or upon discharge. Similarly, medical respite programs could measure and track how often medication reconciliation happens at admission and also at discharge. There are a myriad of clinical outcomes that might be applicable to any particular medical respite programs. And these, for example, could be how often patients with diabetes who are admitted have had an A1C checked within the last 3 or 6 months. There are various clinical measures that could be considered. One that is perhaps unique to medical respite programs and different from typical outpatient metrics is medication errors. So for programs that are licensed to administer medications, the tracking and attempt at improving rates of medication errors is one that could be very important. Could measure how often patients are participating in groups or how often we're successful connecting patients to housing on discharge. Similarly, we could begin to track and measure and work to improve our success rates at helping patients access disability status. I think that wraps up our summary of the standards, and I'll turn it over to Sabrina to review the next steps.
Thanks, Jessie. And I just want to remind folks to enter any questions that you have in the chat box, and we'll get to that during the Q&A. But wanted to let you know what our next steps are in terms of development of these standards. We do currently have an open public comment period right now, so public comments will be accepted until September 30th. Excuse me. I have included a link to the public comment page in this slide. However, those public comments are available on our website, www.nhchc, and you'll just go to our medical respite page. You'll be able to get a copy of the proposed standards as well as a link to the electronic public comment form. So after receiving the comments, the task force that is working on these standards will make revisions to the proposed standards based on discussion of those comments. Once we have another set of proposed standards, we plan to test those at volunteer sites, and those sites are yet to be determined. We'll then make more revisions based on testing, and then we'll issue final standards. What are we going to do with these standards? I think that's a big question that a lot of people have. One, at minimum, we're going to be using these for training and technical assistance. So we'll be working with medical respite programs across the country to get them on the same page of being able to deliver a certain level of medical respite care. We hope to pursue opportunities for accreditation and certification so that medical respite programs can demonstrate or show that they have met these standards. And we also hope for more opportunities in research related to health outcomes, quality of care, and cost as it relates to these standards. And we hope that these will help us in terms of engaging in public discussion or engaging in discussion at the federal level to really be promoting what it is that medical respite programs do across the board, and hope that one day we'll have sustainable funding for medical respite programs. At this point, we'll go into our Q&A session. Again, here I have the link to the page where you can access the proposed standards as well as the electronic public comment form. Our contact information, Dr. Gaeta's contact information, as well as my own, is here. Please feel free to contact us at any point if you have any questions. And so at this point, I'm going to go ahead and go through the questions. And the first question is regarding medication storage. What if the medical respite facility is not licensed? What are the rules regarding prescription medication and administration? And I'm going to ask Jessie to answer that.
Sure. First, I'll say that the regulations around medication administration, that this is a very gray area and that it varies by state. So I can give an example that in Massachusetts, this state really would probably hold clinical staff liable for operating beyond the scope of really not having a license. But actually, this can get a little bit nuanced. I can imagine that some states may look the other way, while others, may feel that this would be a violation of state regulation. So I think it's important to understand the different licensure categories in your state and consider ways that a medical respite program might fit into various licensure categories. And to some extent, that's going to really determine how medications are managed and administered or not.
Great, thank you, Jessie. So the next question is, do you have any sample medical assessment or intake forms and order forms? And we do. We have a medical respite toolkit that's also available from our medical respite page on the Council's website. The medical respite toolkit includes a number of different forms and templates, as well as sample policies and procedures that we think will be helpful for medical respite programs that are planning to formalize some of their policies in some of the areas where they're already doing the work. It just hasn't necessarily been written down. So please do use our medical respite toolkit. It has a lot of information that may be helpful in the work that you're doing. And so the next question is, if you were in the planning process, how would you go about determining the appropriate staff size needed to meet the needs of your patients? That is a really good question. I'm wondering if Jesse, you might be interested in answering that.
Sure. I think you could go about this in lots of different ways. One way I might start to think about it if I was in the planning process would be to conduct a needs assessment of to really think about in the community that I'm in, what is the gap in services, the gap in the continuum of care that this medical respite facility aims to fill. And I probably would then also have discussions with the places that I would expect to get referrals from about what their needs are and who are the patients that they might consider referring or would want to refer to a medical respite program. And so I think I would meet with hospital partners. I would also think about meeting with primary care providers in the area who tend to take care of patients who lack housing, or a healthcare for the homeless, clinicians in the area. And I try to understand to some extent what the disease burden is, and how much, and then would begin to plan for, based on how complex the medical problems are of the patients who would be referred to the facility, and also try to have an understanding of the behavioral health side of things, about just sort of how complex the patients would be who are referred, who you'd want to be able to take care of from a behavioral health standpoint. And for that I really mean both mental illness and also substance use disorders. And then the question becomes, how can I reasonably create a staffing model that we could support financially, and what would that staffing model reasonably look like, such that we feel that taking care of the set of patients who need this service in our community would be safely and efficiently cared for. So one suggestion really would be to conduct a needs assessment.
Great, thank you, Jesse. And so the next question is, when do you think the final standards will be issued? We're aiming for the end of this year, so at the end of 2014 for those to be issued. And then the next question is, do you expect that respite programs will be HRSA, or Health Resources and Services Administration, Health Center grantees, and have to follow the HRSA 19 requirements? If so, some of the standards will duplicate the 19 requirements, for example, credentialing. We do. So about half the medical respite programs, or a little bit less than half the medical respite programs in the country right now, are either administered or co-administered by a health center or a HRSA grantee. And for those programs, we hope the transition will be a little bit more seamless. It's some of the other programs that may not be operated by a health center may have a little bit more work to do in order to get to that level, since they may not have been under those HRSA regulations or governance requirements. And I think that answers that question. The next question, and Jesse, did you want to add anything to that, being that you are also part of a health center?
No, I don't think so.
Okay. So the next question is there a resource that goes over all the licensing that should be considered for the medical respite? I'll go ahead and start with that question. And as far as I know, no. A lot of communities this is a really new concept for a lot of communities, and as such, a lot of their regulatory bodies don't necessarily know how to integrate medical respite into existing regulation. In some situations, the medical respite program has had to, in terms of licensing, fit into some really unique categories in order to make them fit. For example, one medical respite program that I can think of is licensed as a unclassified medical facility. Some are classified as a residential facility, but they partner with their health center, who then is under all the regulations of their health center. And I do want to add that in our proposed standards, we note in there that none of these standards should replace any types of regulatory or statutory rules that you're currently governed under. And Jesse, did you have anything to add?
Yeah, I mean, just that the licensing of clinical facilities is a state operation, and so any resource really would probably need to be state specific. But there are a lot of creative ways, even if our state licensing bodies don't have a category for us yet. There are a lot of creative ways to figure out how to license a medical respite program in existing categories. As an example, in Boston, we're actually licensed as an outpatient clinic. We just happen to have some lodging attached. So it's kind of, there's sort of creative ways to pursue licensing, even without a special category.
Great, thank you. So the next question is, if standards lead to discussions with federal funding, can we expect the same types of reporting requirements similar to FQHCs or CHCs or HCHs? I'm assuming, I'll start by answering this, that most federal funding does come with reporting requirements. So I assume that if you are receiving some sort of funding or reimbursement through a federal entity, you'll be asked to report on your use of those federal funds. And I'm not sure, Jess, if you have anything to add about that.
I don't.
Okay, great. Okay, so the next question is, many patients now have medical insurance. Some respites may not be set up to bill. How has that affected the balance of medical care provided on-site versus outside? Jesse, why don't you talk a little bit about billing for medical respite, and I'll talk a little bit about how sites might get paid outside of expansion or reimbursement mechanisms that are already set up.
Sure. I'm not an expert in this arena, but I guess I would just simply say that the ability to seek reimbursement for the clinical care that's provided, I think is going to ultimately depend on on how you're licensed, and there are rates set for each payer for certain services that are provided by licensed facilities, as an example, in Boston, we are able to, as I mentioned, we're licensed as an outpatient clinic, and the clinical care that we provide is reimbursed for, actually in the same exact way as outpatient care. So when there's a nurse visit in medical respite, we're billing for that as if the visit happened in a clinic. And so reimbursement really depends on the payer and what rates are set up and whether or not a patient has health insurance and that sort of thing. And I wish I could give you a more eloquent answer to that, but I'm not an expert in the reimbursement side.
And I'll add to that, again, reimbursement for medical respite is still something we're working on, so it's difficult to answer specifically. Some medical respite programs are now getting reimbursed by MCOs, and sometimes they're reimbursing medical respite care under care coordination or home monitoring, but they have a code that they're billing under for that. Other times, MCOs might be paying for medical respite care under a grant type of situation, and that might be more conducive for medical respite programs that may not be able to bill. And a lot of this interest from the MCOs or the managed care organization is that they're starting to recognize that medical respite care is helping them to reduce those systems costs and meet some of those quality expectations that they're hoping to demonstrate nationally as well as locally with the work that they're doing.
Sabrina, I thought of two other things to mention, and other examples of ways medical respite can be reimbursed for. One is from our hospital partners through bed reservation agreements. There's a number of programs across the country that have that reimbursement model for some of the care that they provide. Another is just to say that there's opportunity with payment reform as there's movement away from fee-for-service and toward global payments, that in so much as that we can advocate as a community or locally that medical respite care is, ultimately has a lot of value, especially for folks who are very sick and very costly to the system. There's a lot of value in medical respite care, and that global payments should be able to be used for this kind of care. So there's a lot of opportunity, I think, within payment reform down the pike to advocate that these are services that are included in any kind of global payment structures.
Great, thank you, Jessie. The next question is, what is the potential for reimbursement? I think there is good potential. I had mentioned earlier in the webinar that I'm leading an initiative funded by the Center for Medicare and Medicaid Innovation. This is a health reform initiative to determine whether or not medical respite programs lead to improved quality of care, improved health care outcomes, as well as reduced costs. So the intent of this innovation is to determine whether or not the Centers for Medicare and Medicaid Services might make better investments in health care through some of these types of innovative practices. And so there is some potential right now. They're clearly looking at it. We're just waiting to see what those outcomes end up looking like at the end of the demonstration, but it's very promising. The next question is just clarification. What is an MCO? I'm sorry for the use of acronyms. The MCO is a managed care organization generally in charge of payments and coordination of care for Medicaid or Medicare beneficiaries. And are there any more questions? That is the end of all the questions that I have, and I want to offer participants just another minute or so to add any other questions before we end the webinar. Okay, and I do want to, we have a couple more questions coming in. This is a little bit of a longer question, so forgive me. Excuse me. Let's say someone who is not homeless is discharged from the hospital to go to their home to recuperate. Would that person at home receive the level of care, the level of excuse me, the level of record keeping, the interdisciplinary team approach that we have with these standards? I would say in that circumstance, not so much. Jessie, do you want to add to that?
Sure. I guess, if a person who, has housing and is discharged to home, sort of can think about even the example that I used earlier. If you have a patient who now is going to undergo outpatient chemotherapy, oftentimes, there's some support system at home that, to help a patient recover and endure the illness. And of course, it's not a clinical care team. However, I think especially as length of stays in the hospitals are decreasing and patients are discharged earlier and earlier from pretty complex surgeries and with very complex medical conditions, that what we're going to be asked to do in medical respite is to care for patients who are sicker and sicker. And, these are patients who in some cases, who I would imagine going home but needing a visiting nurse, as well as, who has access to, even more clinical backup when needed, and who becomes part of a team approach to caring for that patient, as in the example of a patient undergoing chemotherapy. So what we're not, what we're not doing here is building a home and providing a family, but we are providing clinical support for people who can't go home and don't have clinical support or family support to help them recuperate.
Great, thank you, Jessie. And the next question is, can we focus these standards on providing and coordinating necessary services you described in all 7 areas, perhaps through strong relationships, rather than setting up the respite services as a quasi-clinical facility? I'll take the first stab at answering that. A lot of medical respite programs do provide those services through their partner collaborations. For example, a lot of medical respite programs are co-administered by a shelter as well as by a health center, and the health center in itself then has its own medical director. It then also has the ability to develop individualized care plans and make those types of clinical discharge or admission decisions. That's one way that relationships have been able to, these types of strong relationships have been able to accommodate a medical respite program, particularly in areas where they may not be so resource heavy and they can't hire their own independent clinical staff to deliver services at that facility. Jesse, did you want to add to that?
No, I don't have anything to add.
Okay, great. Well, that concludes our Q&A session. We have no more questions. Again, please comment on the proposed standards. We hope to receive your comments by September 30th, and then we will be providing more information as we begin to further develop these standards. I really appreciate you participating in this webinar. We do ask that you complete the survey that will, for this webinar. It will help us improve future webinars and your webinar experience. Again, a link of the archived webinar will be emailed to you once it's posted on our website. The meeting will now be closed.